Hello, everyone. Welcome to the Q&A session on indolent non-Hodgkin lymphomas and CLL. My name is Gurjot, and if you've seen me in the previous session, you would know that I'm the Manager of Patient Programs, Research, and Advocacy here at Lymphoma Canada. I will be the facilitator for this session today. I'm pleased to welcome here Dr. Anthea Peters, Dr. Mary Margaret Keating, and Dr. David McDonald. Dr. Carolyn Owens may be potentially joining us later on. She's the presenter you saw for the CLL session, but we have some great presenters here, including Dr. David McDonald, who would be able to speak on the topic of CLL. And with that said, just a reminder to the audience, if you do have questions, please be sure to put it in the chat option, and you can find that at the bottom of your screen in the black panel. So we will begin. And we do have a question in regards to, okay, we'll start off. It's a general question. How bad is alcohol consumption for a non-Hodgkin lymphoma? And anyone can take this question. It's a general one.
I guess I could start. I don't know if there's any specific data. I know the Canadian guidelines for alcohol consumption were recently updated and are quite strict in terms of health with like, I think 2 to 3 drinks per week max, maybe for females. And I'm not sure about for males, but I think probably less is more. We don't really know how alcohol affects the immune system and, you know, the ability of that to the inflammation of excessive alcohol intake on the stress of your body, but I don't know of any data in that. I don't know, Dave or Anthea, if you are aware of anything.
No, I don't have any specific data that I know of for lymphoma. So just the general guidelines would be good to follow.
Okay.
Yeah.
Mhm.
Sorry, I was just going to say, I think that it depends a bit on the situation, right? Like, I think that somebody who is in remission after treatment is different than somebody who is on chemotherapy, and there are different reasons to, minimize or abstain from alcohol while you're on active treatment.
Okay. And the next question we have here, it's kind of situational as well. So I have CLL/SLL. When I asked my hematologist at my non-research, non-teaching hospital here in Ontario about enrolling in a clinical trial, the answer was somewhat dismissive. Can a patient initiate enrolling in a clinical trial?
I could take this one because it's near and dear to my heart. It's disappointing to hear that you had a dismissive response to that, because I think many of us, at least in academic medicine and even in community medicine, really do value participation in clinical trials. You can't technically refer yourself to a specialist outside of your center, but what you can do is you can reach out to a principal investigator at a site. Let us know that you may be interested in a clinical trial that we might have open, and that you've brought it up with your hematologist. And we certainly are not shy to reach out to our colleagues and say, hey, this may be a reasonable option for this individual. So we might be able to facilitate it that way.
And we have a few more follow-up questions on clinical trials. So would you know of any clinical trials in Canada that are currently recruiting for Waldenstrom's patients after first-line BR treatments, or generally, how can patients go about finding more information about these clinical trials?
Well, I did the session on Waldenstrom. I mean, at our center, we don't currently have any trials open aside from a frontline clinical trial that's being sort of organized by, oh, I'm blanking on his name, but it's an investigator from Toronto, and there's several Canadian sites. So it's looking at bendamustine and rituximab with the addition of acalabrutinib in the frontline setting. So I could do a little look to see if there's any other trials open in Canada, but David, Mary Margaret, do you know of any at your centers for relapsed Waldenstrom?
So we have the BROM study that you mentioned as well. Fortunately, that's finished its recruitment. So it's patients have been treated, and that's in follow-up now. We do have a study for patients who have relapsed twice. So they have to have had prior BTK inhibitor like ibrutinib. And that's a study of nemtabrutinib, which is a non-covalent, reversible BTK inhibitor. I saw a question pop up in the chat, and it's related to this, and that is, how do you find out what clinical trials are out there? And there's various ways of doing that. Some of the cancer centers have websites that list the clinical trials that they have available to them. Sunnybrook does that, I know. But otherwise, the way I do it is I go on clinicaltrials.gov, which is a database of all of the registered clinical trials, and you can search by what disease you have. You can search by, relapsed or previously untreated, and you can search according to geography. So you can find out what trials, quickly you can find out all trials open in Waldenstrom's in Canada, and then sort of narrow it down from there.
Thank you, Dr. McDonald.
I'll just add, I'm sure we just opened a Waldenstrom study that I think is for relapse. So I'll get back to you. I was searching my email because I can't remember exactly about it right now. We opened so many studies and I'm not the PI on it. So I'll let you know. Oh yes, we have the one. I just texted the PI. He said it's for people who relapse after what we call a BTK inhibitor, so ibrutinib or a acalabrutinib, or they're intolerant to that sort of drug, and it's getting a newer drug called sonrotoclax, which is sort of similar to a drug that's used frequently in CLL called venetoclax. So that we just opened that recently, like in the last few weeks. Things are always opening and closing with clinical trials. So whenever we have a lymphoma patient, we always are thinking, what clinical trials do we have? So you can see for a community physician, it's very challenging to keep up, because even for us at our centers, it's hard. We always have to be asking every time, okay, is a study open? Is a study enrolling? So yeah, clinicaltrials.gov is always good to look at, because it will say what centers in Canada have it open if you search your disease, basically.
Thank you. And we do have a few questions on follicular lymphoma. So again, I'll direct those to Dr. Keating. So what are possible treatment options for indolent follicular lymphoma that has spread into the spinal canal? Are there chemo/targeted therapies that can get into the spinal canal, or is surgery a more likely option?
All right. Can I answer the easier question on top of that first, and then I'll come to that one?
Yep. So
but I just see there was one that said, what do you look for in blood work with follicular lymphoma, just above the one you just read, which I did mention in my talk, but it is a bit long. But I always tell patients blood work is just one part of what we're looking at. You can have totally normal blood work and have significant follicular lymphoma still, or maybe even lymphoma that needs treatment. But the blood work is important. We look at your blood counts. If they're significantly low, we're always considering, is that from your lymphoma? Additionally, if you have a lymph node mass that could be pushing on a kidney or liver, those numbers can become abnormal. So always check your kidney and liver number. And we usually check your calcium level. Elevated calcium happens more with fast-growing lymphomas. So if we saw a sudden elevation in your calcium level, we'd want to look into things a bit more. So I think those would be the most common things to check with follicular lymphoma. Again, that's just one part of the assessment. How you're feeling and your physical exam are also important. The second question, it would be very rare to see follicular lymphoma in the spinal canal. I'm not sure if I've ever seen that. I have seen some other indolent lymphomas in the spinal canal, like in the fluid. I'm not sure if you mean in the fluid or outside, like a mass pushing on the spinal canal. Those would be slightly different things. If it was a lymph node mass close to the spinal canal, that would be treated with normal, usually chemo, immunotherapy, and or radiation, depending on the acuteness of the situation. Like if you were having neurologic symptoms, we wouldn't do surgery to remove that typically, unless there was a diagnosis question, unless we were wondering, has your slow growing lymphoma changed to a fast growing lymphoma? Then sometimes we might ask for a biopsy of that spot. If you mean within the spinal fluid, like within the brain area, that's a different situation that would need we'd usually give chemo into that liquid fluid and or other high dose chemotherapy. But I don't know, Dave or Anthony, I've never seen follicular lymphoma in the CSF that I can think of. I mean, CLL, mantle cell, obviously large cell lymphoma, but not follicular. Waldenstrom's, most other ones.
I can't think of a case either.
So maybe it's meaning
So it's
pushing on the
probably,
spinal, like maybe more of a lymph node mass question.
But your answer was great. I would have said the same thing.
Perfect. Thank you. And we'll move on to the next question. If one, this is a general question, if one is run down and weak and has a weak immune system, does that allow lymphoma to take advantage and grow? Anyone, Dr. Peters, Dr. Keaton?
I think there's a theme, and I do talk about these with my patients. Like, I think the alcohol question, the rundown immune system, lifestyle changes, like common themes like that I see in the questions. And I think why we're a little bit more silent is because there is no evidence, like there's no studies that I'm aware of. Again, you know, someone can chime in if they know, that tell us for sure that, you know, eating healthy and exercising and not drinking alcohol will help your lymphoma stay in remission longer or help you respond better to treatment, that we know of. I think those are good things for you. And I think the most important thing with those type of questions and ideas is I always tell people you're going to have the slow growing lymphomas for a very long time, or even other lymphomas. And when I do need to treat you, or if I want to treat you when you're older, it's better if you don't had a heart attack or a stroke or have kidney problems from high blood pressure that's not been managed. So I think following up on those lifestyle things are super important to keep your body healthy enough so that I can treat you easier as we move along, is usually how I talk about those things.
Dr. McDonald, did you want to comment on that?
Yeah, so thanks, Dr. Keating. I say exactly the same thing. And it's a common question, and I think it's a great question. And I wish that there was more data, more clinical trials that looked at how specific lifestyle interventions could have an impact on, you know, risk of relapse and so on. Because I think, you know, it's compelling as a patient to want to do something proactively during that watchful waiting stage, or that, you know, I'm in remission now, but I know it's going to come back stage. And it's hard for me as an oncologist to say, well, there isn't really anything that you can do. So I don't say that. I say exactly what Dr. Keating says. That is, you know, I think that the better lifestyle choices you can make now with regards to having a healthy weight, you know, minimizing alcohol, not smoking, and getting good exercise, the fitter you'll be, so that when it is time to treat you, you will do better. And I imagine that if there was an intervention trial that looked at that, that we would prove that. And it wouldn't be because, you know, a particular vegetable or vitamin was affecting your outcome. It would be that you've adopted those lifestyle changes, and that improved your fitness, your ability to take more treatment, and that's what's going to improve the outcome. I think, unfortunately, you can go to your local chapters or Indigo and go to the health book section, and you'll find all kinds of books on what to eat and what not to eat. And unfortunately, I don't think that there's a lot of good evidence that goes into what people are publishing in those venues.
And in that regard, I just want to remind the audience that we do have a panel discussion taking place tomorrow, and we are featuring a registered dietitian who was also a lymphoma patient. So you may be interested in attending that session and hearing more on what she has to say. And we have another question on follicular lymphoma. So this patient finished treatment with R-CHOP in January of 2020 for follicular lymphoma, which was thought to be transforming to large B cell, even though biopsy only showed follicular lymphoma. Lymph cells started to grow again. Would next treatment be BR or some form of targeted treatment?
Yeah, so tricky situation. We've mentioned this transformation a couple times, and I talk about it in my talk as well. But there's about a 3% risk on average per year that a follicular lymphoma can switch to a fast-growing lymphoma. And sometimes we can't prove that. Like, they did the right thing to biopsy; it only showed follicular. But maybe there was something about your clinical case that was behaving more aggressively, that they were nervous to give you follicular chemo, so they gave you large cell chemo, which we do sometimes, because you can't just keep biopsying someone, or maybe there's an area they were worried about they couldn't biopsy. If they're growing back early, that would be concerning. Again, not knowing the exact case. I mean, normally we would consider, you know, whether you do a PET scan and another biopsy to see if you can prove. It's quite important actually to improve it, to try and prove it's large cell at some point, because it does affect your treatment options, especially when you're talking about relapse disease. So I don't think somebody would just give you BR without rebiopsying. Again, hard to say without knowing exactly the situation and how big are the lymph nodes and how quickly are they growing and how does everything else look. But if there was a concern that this is a fast-growing lymphoma that has not gotten into remission or stayed in remission, then it depends on your age and fitness. You can get chemo and a type of bone marrow transplant, a stem cell transplant would be our usual standard, and depending on what province you're in, CAR T-cell therapy would be after 2 lines of therapy for a large cell. But probably you'd want to try and prove this as large cell a little bit harder this time around, I would think.
Okay, perfect. And with that, we'll move on to a question for the general panel. Has there been any research to find out how people with blood cancers are faring with COVID vaccinations, admissions to hospitals, long COVID deaths, etc.?
I can try to tackle this one. The answer is yes. There were a lot of studies. You know, when the COVID pandemic started, it caught us all by surprise, right? Nobody spent a decade planning what their big study was going to be in the next pandemic. The pandemic hit, and then we were, you know, scrambling to try to make the most of patient outcomes, but also trying to make the most of our opportunity to learn. One thing that did become clear was that the exposure to rituximab does impair the ability to mount a immune response to the vaccine. So there's very good data from a lot of different studies looking at patients with CLL and with different types of lymphomas who are currently on or had been on rituximab, giving them COVID vaccination and then measuring whether they had a response that showed that the number of patients that responded to the COVID vaccine was disappointingly low. And it really, in studies that looked at the number of months after the last exposure to rituximab and correlated that to the success of vaccines, it showed that it takes about 9 months before your immune system can have a response to COVID vaccine that's similar to somebody who's not had rituximab. So that's one thing. And then in terms of COVID outcomes and COVID deaths, yes, absolutely. Lymphoma patients were disproportionately hit with bad outcomes for patients who had COVID, more admissions to the ICU, longer admissions to hospital, and more deaths. So we learned a lot, and hopefully we will be more prepared the next time around.
Thank you, Dr. McDonald. The next question here is, what would you do if your hematologist says blood work is not really important? I see people talk about markers, but she says it doesn't tell you anything. What are your thoughts on the importance of monitoring blood work?
I guess I can follow up to what I said earlier. It's not everything, so certainly, and there's subtle blood work changes that are not concerning to us. So perhaps there was something that marked abnormal in the blood work that your hematologist wasn't excited about, and that does happen often. LDH can go up and down. You mentioned that there in the question. We follow LDH, but I say that with a grain of salt because it's not really a marker of lymphoma per se. It's something, if LDH started really rising, whatever that I feel that is significant, you know, I usually look a bit closer at things. Sometimes I consider a scan, not always. Again, I would follow it up. But you know, some people have LDHs that go up and down, and certainly their lymphoma is in remission. So it can lead you on a little bit of a wild goose chase sometimes, but sometimes it's helpful. So different people might have different ways they practice with that. I wouldn't say that blood work, I wouldn't say that blood work isn't important. I would definitely say it's not the only thing that you need to monitor, and you can have totally normal blood work and very significant lymphoma that needs treatment. So it's reassuring when blood work's normal, but I wouldn't stop there for sure in watchful waiting times.
Thank you, Dr. Keating. Now we have a few questions involving CLL/SLL, so I'll direct those towards Dr. McDonald. So how common is CNS involvement with CLL?
It's a good question. I don't have exact numbers, except to say, similar to discussion before, it's actually quite rare, CNS involvement. But that is to say, the three of us here, I'm sure we've all seen patients with CLL who have had CNS involvement, but it's not very common at all. If it does occur, it usually does in the context of a Richter's transformation, unfortunately.
Thank you. And the next question, my brother and I were both diagnosed with SLL last year. There's no family history of cancer. We're close in age and had similar symptoms, yet different treatment plans. He is on ibrutinib for at least 7 years. I'm on obinutuzumab and venetoclax combination for 1 year. So what determines treatment path?
Well, that's actually a huge question. I mean, I think in the case of the you and your brother, the time that you were diagnosed had the greatest impact on your treatment path. I think, ibrutinib and acalabrutinib, well, ibrutinib has been around the longest. Venetoclax then came in, and then acalabrutinib and zanubrutinib sort of followed. And, it's been an exciting time in CLL, but it's also been a challenge because the sort of standard of care or the standard treatment pathway or treatment sequence keeps changing as newer evidence and newer agents come in. I think so. I touched a little bit on CLL pathways in my overview talk on sort of upcoming treatments, and BTK inhibitors, acalabrutinib and zanubrutinib, I think are excellent options for anybody with CLL. Venetoclax and obinutuzumab, I think, is an excellent option for most patients with CLL. I think, that people who have a deletion 17p or a TP53 mutation will probably have a longer duration of benefit from a BTK inhibitor rather than venetoclax or obinutuzumab. But even then, I think it's still a good option for some of those patients with the higher risk disease. And I think you said that you're taking the combination. Oh, you're on obinutuzumab and venetoclax, yeah. I think time-limited therapy is very desirable for a lot of patients. So there are situations where, we may have evidence that says a BTK inhibitor might give a better or a longer remission, but that's continuous therapy. And, you may, as an individual, say, you know what, I'd rather take 1 year of therapy and have a good long remission, even if it isn't as long as I might have got with continuous therapy. And then, you would go on a BTK inhibitor in your second line. So there's patient factors in terms of choice, preference, how close you are to the center, the convenience and inconvenience of one versus another. And then there's disease factors in terms of the genetic risk categories and which disease factors are more likely to respond to one or another. And then there's funding issues, of course. It's just such a complicated question.
Thank you, Dr. McDonald. Moving on to the next question. Is there anything we can do if we have low immunoglobulin levels besides IVIG treatment?
We certainly are using immunoglobulins a lot more now in patients. At least I am. I shouldn't speak for everyone. But I offer people IVIG or subcutaneous immunoglobulins. So there's a couple of different formulations of subcutaneous immunoglobulin now, which you can give at home. One is weekly, one is once a month. Pros and cons to each option. But there's no booster otherwise. Those are chronic treatments. If you stop them, usually your IgG level remains low, depending on your disease state and if it's a chronic lymphoma and treatment and whatnot. But there's nothing else that will raise those levels other than giving immunoglobulin either by a sub-Q or IV infusion, as far as I'm aware.
Thank you, Dr. Keating. And the next question, how much variation in IgM levels can be regarded as not significant after first-line treatment? Sorry, the question got lost on me because there's more questions coming in the chat. Okay, so I'll start again. How much variation in IgM levels can be regarded as not significant after first-line treatment? IgM was at 62 prior to treatment, was reduced to 9 in the year following treatment, now has bounced up to 13.
I guess I'll take that one. So yeah, I mean, it sounds like you had an excellent response to treatment with an IgM going from 62 to 9. It would be considered a very good partial response, not a complete response, but it's very, very common for IgM not to go completely down to 0. And then we just follow. It seems like the IgM has bounced back up, but keep in mind that that doesn't necessarily mean that you're relapsing. I mean, there's no real particular percentage to say that you're relapsing. It just depends on the clinical scenario and whether there's lymph nodes that are growing as well, or spleen. And certainly we wouldn't reintroduce treatment with just a slight increase in the IgM. We would look at the whole picture and look at your symptoms, again, the lymph nodes, the spleen size, and so on. And it sometimes does vary. You might find that the next time your IgM is measured, it's come back down. So it can bounce up and down a little bit.
Thank you, Dr. Peters, for clarifying. Next question. I've completed treatment with the bendamustine and rituximab 6 cycles. I'm subject to infections. Is it normal to be on antibiotics continuously? I'll leave that open to anyone.
Kind of goes a little bit with the IVIG question we had. Some patients definitely are more prone with rituximab will increase respiratory sinus type infections, I would say most commonly. And some patients do have recurrent sinusitis or upper respiratory type infections, which is really problematic. Recurrent antibiotics, you get them to see ENT, but really it's the treatment suppressing your B cells, and why some people get that more than others. The B white blood cells is hard to say. Your IgG level may be low. If your IgG level is very low, that's your immunoglobulin, your immune protein G, then perhaps you would benefit from IVIG or having infusions of that if you're having a lot of recurrent infections. But it is a risk, and some patients have that more than others, and that's we don't know exactly why, but it's a known risk of the treatment. I don't know if anyone else has any other comments on that.
Okay, moving on to another question. This one's related to CLL, so I'll direct it to Dr. David McDonald. What percentage of relapse happens after R-CHOP and stem cell transplant for treating CLL Richter's transformation to DLBCL? Markers include non-mutated 17p deletion.
So that's also a great question. And the reason it's a great question for me is when you're looking for statistical probabilities of relapse, we don't have the same size of trials of stem cell transplant in Richter's transformation to really be able to answer that question. At least I'm not aware of them. They may exist, but certainly it's a rare enough disease that they would not be sort of on the same scale as the large randomized controlled trials that we do of different therapies prior to autologous stem cell transplant. So, and secondly, we don't really know, just looking at your question, but I can't see it all. Markers include non-mutated 17p deletion. Is that to say that you do have a 17p deletion? If you do, then certainly that increased your risk of developing the Richters in the first place, and it increases the risk that you're going to have a relapse after your transplant. I don't personally consider autologous stem cell transplant to be a curative treatment for Richter's transformation or of CLL. I think that patients with CLL and Richter's transformation, in order to have a curative transplant, it would have to be an allogeneic stem cell transplant. But you know, CAR T is becoming an available therapy soon, I think, for Richter's transformation, and then that provides new hope for those patients. But in terms of your risk, I don't know how to predict that.
Yeah, thank you, Dr. McDonald. I think that will be the last question for the day. To conclude this Q&A session, I would like to thank all of the doctors who have joined us today. We hope those watching today learned something new about their own or their loved one's lymphoma subtype. And with that said, please tune into the next session titled Symptoms and Side Effects Management for Lymphoma Patients. Thank you, everyone, and see you there.
Thanks so much.